Assalamualaikum warahmatullahi wabarakatuh. I am Javeria Dar, roll number BP 1650102 from Final Prof Morning, and I am going to present the case study for clavulanic acid. First of all, I am going to give the brief information for the clavulanic acid. It is a beta lactamase inhibitor and it has very negligible antibacterial activity or any kind of drug activity. It is not a drug, but it is given with the drug in the regimen to enhance the activity of beta lactam antibiotics. It is given in the regimen with amoxicillin in the ratios of 2:1, 4:1, 7:1, 14:1 or 16:1. How it works, how it protects the drug from the degradation. Actually, the bacteria tend to degrade the beta-lactam ring of the antibiotics, mostly the penicillin and cephalosporins. So we add clavulanic acid in the regimen. Clavulanic acid is a beta-lactamase inhibitor. It inhibits the beta-lactamase enzyme of the bacteria, and in this way it protects the drug from the degradation. The formulation that we get is co-amoxiclave. It is indicated in the conditions like tonsillitis, bronchitis, pneumonia, and mostly it is given in the UTIs. It covers streptococci, staphylococci, E. coli, chlamydia, legionella, and many other bacteria. It is contraindicated when the person is hypersensitive or he is already suffering from glandular fever, and if the person is renal compromised, then there is the need of dose adjustment. The side effects that many people go through are hypersensitivity reaction, pseudomembranous colitis, nephritis, neurotoxicity, and cation toxicity. Means it affects kidneys as well as CNS, the GI, and there is cation toxicity. The drug interactions are as follows. It decreases the effects of BCG vaccine. It increases the anticoagulant effect of warfarin. Azithromycin decreases the effect of amoxicillin, so we cannot give the two drugs together. Allopurinol increases the allergic potential for amoxicillin. So if a person is already somewhat sensitive or allergic to amoxicillin, we cannot give him amoxicillin, or by chance if he gets amoxicillin as well as allopurinol, then the condition can get very bad. Now there is rational use and irrational use for the clavulanic acid. The rational use includes when it is given against only the sensitive species, when it is given in the proper dose, that is under the rational use. It is prescribed by the physician, and when the person is completing the prescribed course, that is the rational use of the drug. It is also irrationally used. For example, clavulanic acid being used alone without amoxicillin, that is out of the regimen, or underdose prescription, not completing the course of the therapy, self-medication, or using it against the resistant bacteria. If the person is already resistant, there is no use of taking this drug. And treatment of non-bacterial diseases, because it covers only the bacteria. Alternative drugs, if the person is allergic to this drug, then we cannot give him this drug, and we have the following alternatives like clarithromycin and doxycycline, because these drugs do not have the problem of hypersensitivity. The available dosage forms for this drug are parenteral, and we will prefer the parenteral in the case when the bacterial infection is so high, so we have to give the loading dose, and loading dose is always given, or mostly it is given through IV route. And for the unconscious patient, because he cannot take it through the oral route, so we have to go for the IV. Now the second formulation or the dosage form that is available is tablet or capsule. Tablet or capsule are given when the patient is adult, he is conscious, or he is on the maintenance therapy, because he can take tablet and capsule. Now the oral suspensions are for the infants or for the patients who are going through dysphagia, because they cannot swallow the tablet or capsule. That is why we give them oral suspension. There is dose variation in the population. There is a separate dose for pediatric, geriatric, and pregnant women. For the pediatric, the dose is 6 mg per kilogram. For the geriatric, it's 1000 mg amox and 200 mg clav. For the pregnant, it must be avoided in the pregnant ladies. We do not give it to the pregnant women. The cost-effective brands which are available in Pakistan are three. The first one is Mclav. The price per tablet is 10 rupees. The Calamox, the price for 6 tablets is 75, so per tablet it is around 12. And then Augmentin, 82 rupees for 6 tablets, so the price per tablet will be around 14 rupees. Now we have the clinical case study. A patient who was 20-year-old woman, her name is VQ. She had no previous history of UTI, and she came to the hospital with a burning urination and frequent urination in a small amount and the bladder pain. She has no fever, or severe tenderness, and her urine samples were taken and it showed gram negative rods in the gram stain, and then the culture sensitivity was done, and she was presumed to have a lower UTI. Then we go for the subjective. She has no as such past medical history. She is not taking any medicines. Her mother has diabetes mellitus, so that comes under the family history. The social history is that she is not a smoker. She occasionally uses marijuana, and she is sexually active, and she has one partner for the past 9 months. The representation of the symptoms is urethral pain, burning during the urination that she is complaining of, suprapubic tenderness, and there is no urethral or vaginal discharge. There is no current medication that she is taking, and she has no known allergies with any drug or any other food content. The objective, we took the physical examination. Her blood pressure was normal, the pulse was normal, temperature was normal, and the weight and height are given. She had mild suprapubic tenderness. The lab analysis showed yellow cloudy urine with a pH 5.0. Leukocyte count was 10 to 5 cells per HPF, which was quite high because normal leukocyte count in the urine is 1 to 5 sorry. Erythrocytes are 1 to 5, which is normal because these are normally less than 5 or less than 4, so it is normal. Proteins are 10 milligram per deciliter. These are again high. There is even blood is present in the urine. The glucose is absent, and there is excessive blood bacterial growth observed under the microscope. Assessment, we assess that patient has acute uncomplicated cystitis. Cystitis is the inflammation or the infection of the lower urinary tract, or we can say the bladder. There are white blood cells are appearing in the urine. We can see the leukocyte count is higher, which means WBCs are appearing in the urine. There is appearance of blood indicates mild hemorrhage. There is even there is very mild bleeding due to the infection. We have to go for the differential diagnosis because we want to rule out the chances of syphilis and cervicitis. So after ruling out the chances of these two, we know that it is actually cystitis. The plan, when the microbial sensitivity was done using the Kirby-Boer method, which is actually a method to determine the microbial sensitivity against the drugs, she was found sensitive to amoxicillin, so she was given tablet co-amoxiclav 250 milligram by 125 milligram. 250 milligram is amoxicillin and 125 milligram is clavulanic acid in this formulation. Since she has mild cystitis, that is why we are not given her high doses. 250 by 125 per oral every 8 hours, and duration of therapy will be 3 days. The co-therapy that she will be advised for is to consume cranberry sachet because cranberry is found good to treat the UTIs and to prevent the further damage. She must ensure maximum intake of water and she must take fibrous food. The follow-up plan for this patient is that she is asked to come for the examination again after 3 days, and after 3 days she will be completely physically checked for fever, any pain, or if the tenderness is there or not, and there will be urine analysis performed to make sure that the bacterial growth is now absent, and we will also check that if blood and leukocytes are appearing in the urine or not. If we see that there is no improvement observed, or if we see that the symptoms are getting worse and she is not feeling any better, then the therapy will be stopped and the patient will be shifted to other drugs. The other drugs that we will have are sulfonamides or tetracyclines according to the sensitivity data. We will see if the patient is sensitive to sulfonamide or either tetracyclines, and we will shift her to the other drug. And here are the references that I have used. Mostly I have used Remington for the drug data, and for the pharmacological data I have used the Lippincotts, and other references are also mentioned. Thank you so much.